Hello, today we're going to go over post-operative complications as part of the colorectal surgery bootcamp series for incoming fellows. First one that we're going to talk about is anastomotic stricture. Many of these complications may be familiar to you with general surgery, though we're going to talk a little bit about treatment and incidences as well as risk factors for the things that you'll be seeing this year. There's a 3 to 30% rate of stricture, which is usually higher with the pouch anal anastomoses has the highest rate of stricture. Contributing factors obviously are going to be blood supply, hemorrhage, a lot of times abscesses or from anastomotic leak can cause stricture, and obviously previous radiation. These patients can either get increasing constipation with the thinning stools, or they can also get overflow diarrhea because the stricture is causing a partial obstruction. Asymptomatic patients with stricture can be identified at the time when you're getting ready to take down the diverting stoma by either contrast evaluation or endoscopic evaluation. The treatment, if they're short strictures, either in colorectal or coloanal anastomoses, you can maybe be able to do digital dilation if you can reach it with your finger. This is typically an outpatient procedure. If it's very tight, may need to be used with Hagar dilators to assist. And distal narrow strictures, like we talked about, that don't admit the tip of your finger, will have to start with something even smaller, like a 4 or a 6 size Hagar dilator, and you can slowly work your way up. The balloon dilations work for short, usually less than 1 centimeter colonic and colorectal strictures. The success rate of balloon dilation is quite high, though it may require additional dilations if the stricture recurs. Anastomotic bleeding presents similar to lower GI bleeds for other causes that you've seen throughout general surgery residency training. These are difficult to treat with interventional radiology and just having them embolize it, because obviously then you worry about knocking off the blood supply to your anastomosis. The optimal treatment will depend on the site of bleeding, patient factors, and your ability to get there as an endoscopist to take care of this. So conservative treatment is typically first blood product transfusion typically is all that's needed. Sometimes endoscopic therapy if this is an early bleed, and a lot of times after you finish creating the anastomosis, you'll evaluate it with a flex sig to look for any arterial bleeding that may need a clip at that time. We discussed embolization. You can inject epinephrine or locally vasoactive substances, or you may have to reoperate if the bleeding is severe. Prevention is to avoid inclusion of the mesocolon into your staple line if you're doing a side-to-side or even an end-to-end anastomosis, and intraoperative assessment as we discussed. So the leak rate, anastomotic leaks are obviously something that you will see this year, as I'm sure you saw them in general surgery residency. The incidence varies widely depending on the literature that you're reading. Some reports is around 20%, some reports is lower. It is highest in colorectal and coloanal anastomoses with a mortality that's 10 to 15%. Obesity, COPD, due to, again, relative hypoxia, immunosuppression, and smokers are patient-related factors. Disease-related factors are, the lower that you go in the colon, the higher leak rate, as well as maybe previously radiation for malignancy. And then surgery-related, this has been something that is not new to you, is tension, patient condition if they're on vasopressors, duration of surgery, and all those factors listed there. So the management always requires a high index of suspicion. Patient may get worsening abdominal pain. They're just not progressing after surgery as you'd expect them to. Obviously, a high white count and fevers. Early leaks present within a week of surgery. It can be subclinical with things that we had mentioned above, or they can get floridly septic. Options would include to do a resection and redo the anastomosis. It could be to wash out the pelvis, place drains, and try to locally repair your anastomosis. It can be just to divert it with drain placement, or it can be even just take down your anastomosis and make an encolostomy. A lot of it's going to depend on your patient factors. Late leaks happen beyond 7 to 10 days. IV antibiotics and percutaneous drainage, a lot of times we'll get these patients through. Ureteral injury is another complication you'll see specifically, and we'll talk about these. Some of these happen because of stent placement, not because you didn't put stents in. So there's two different classifications: the timing, early versus delayed detection, and then the location of in the ureter. The detection methods are, if you have a drain, you might have increased drain output that you would want to check for creatinine. You also, if you don't have a drain and your creatinine's going high, it may be because you tied off the ureter. These patients can also get flank pain or an ileus. If you suspect a ureteral injury, typically a CT urogram may be the best option. However, if you're doing it because of an elevated creatinine, then you're not going to want to give that patient dye. Renal ultrasound can tip you off to hydronephrosis, and then urologists, the retrograde cystogram is going to be the best. Options for treatment are to stent across the injury and hopefully allow that to heal. Immediate repair, if it's an early leak, has better outcomes, or delayed repair and temporary nephrostomy tube placement may be what you need to do if it's a late identification. So the timing is key, as we discussed. The success with an early repair before 1 week after surgery is much higher. The stenting, as everybody knows, helps only with earlier intra-op identification of injuries. It does not stop you from injuring the ureter. And the complications, like I mentioned, you can get ureteral perforation from trying to place a guide wire through a fibrotic or scarred-in ureter. You can get reflux anuria, where the ureter spasms when you take out the stent, and it can mimic a ureteral injury. And obviously can cause hematuria or a urinary tract infection. Stoma complications have different categories. All these things can happen to your stoma after surgery. High output ileostomies is very common, and we'll kind of briefly touch over ways to deal with that. Ischemia would be your other in-hospital post-operative finding, and the others there can happen once you see them in clinic. So a series of medications at your institution probably has a very well-defined stepwise fashion as far as medications to start adding to decrease the stoma output, and those are all listed there. The last resort would be to place a PICC or a long-term IV catheter for IV fluids at night, or if it's possible to do an earlier reversal than you had previously planned. Stoma necrosis, the big thing is going to be to identify the depth of your necrosis. Sometimes you can use a glass test tube or an endoscopy to see how far the necrosis extends. Obviously, if it's below the fascia, you have to go to the operating room because it will eventually perforate and cause an intra-abdominal infection or sepsis. If it's above the fascia, sometimes you can wait that out, and that you may just get some mucosal sloughing. The risk factors obviously are higher, again, for smokers. It's more common with the colostomy than ileostomy because the blood supply of the colon can be finicky if you're relying on a marginal artery on the left side. Obesity and small fascial defects. So last, we're going to talk about low anterior resection syndrome, which, if you're not familiar with a lot of colorectal surgery at this point, patients that undergo a very low anterior resection can have bowel dysfunction. This happens at least to 50 to 70% of patients, and these symptoms include incontinence, urgency, frequency, and the big one is clustering, where they'll wake up in the morning and then they'll say they have 5 or 6 more trips to the bathroom in the morning because they feel like they don't empty completely. Pathophysiology is for many things. Obviously, you're taking out the rectum, which has a huge reservoir capacity, so you're relying on a colon that's not used to accommodating a large stool burden to become your new reservoir. You get disruption of your rectoanal inhibitory reflex. You've cut through some of the nerves that innervate the lower aspect of the rectum to do your lower anterior resection, and you can get some internal anal sphincter dysfunction. As we said, ultra-low anastomoses, total mesorectal excision, and then radiation can all increase the symptoms associated with LARS. The treatment is fiber, diet modification, antidiarrheals or bowel sequestrants. Some say serotonin receptor antagonists can help, and it's important to make sure that you counsel the patient both pre-op and immediately post-op that these symptoms can be present for months to years. They're normal. Their bowel habits will take a while to adapt, and these are some medications that you can use to help get them through this adjustment period. That's it for this presentation. Thank you very much, and have a good day.